Everyone to today's webinar, The Evidence for Value-Based Care, What Succeeded and What's Failed. On behalf of Becker's Healthcare, thank you for joining us today. Before we begin, I'm going to walk through a few quick housekeeping instructions. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We're here to help. With that, I'm pleased to welcome today's speaker, Dr. Wael Barsoum, President and Chief Transformation Officer at Healthcare Outcomes Performance Company. Dr. Barsoum, thank you for being here today. I'll now turn the floor over to you.
Thank you so much, Katie. It's truly a pleasure to participate, and I'm actually very excited about the topic that we're speaking about today. When I was first asked about giving a presentation for the Becker's webinar and had some different options, I very purposefully chose this topic. And the reason I chose it is because I feel that as we're starting to lean in more and more on value-based care, there are a lot of acronyms and a lot of topics that many folks don't really have a lot of direct experience with, as well as a long track record of both successes and failures. And as we all know, we learn probably more from our failures than we do from our successes. So I thought it would be worthwhile to actually spend some time and talk about some of these. So the objectives for today are really to talk about some of the key reasons behind various value-based care model successes. In addition to that, I would actually say also define what some of these value-based care models are. In addition, we'll talk about why some value-based care models have failed and look at some of the trends that are shaping the future of healthcare delivery and really learning from some of our past mistakes in terms of doing it better in the future. So I'll start by bringing everybody back to the equation that we talk about when we describe value. And this really comes from Michael Porter's work from Harvard Business School, where he defined value as quality divided by cost. Many folks have actually expanded on that definition that has now included outcomes, patient experience, accessibility, maybe even outcomes that are important to the patient divided by overall cost. And as we think through that value equation, we realize that we really utilize it in everyday life, whether you choose to have cable television or you've cut the cord per se and are using, like an Amazon Fire Stick or a Roku. Are you getting better value for that experience? Well, it's the same thing in healthcare. Patients ought to have the opportunity to choose their providers and to choose their healthcare delivery models based on the fact that they're getting what they perceive to be the most for their money. And this becomes extraordinarily important when we start thinking more and more about the fact that we truly are on an unsustainable path to success in healthcare here in the United States. In 2020, we spent about $4 trillion in healthcare. Last year alone, our healthcare inflation rate was 10%. This made up about 20% of the gross domestic product. A fair amount of that spend actually goes into musculoskeletal care. But just a couple sobering statistics that I think are important for folks to understand. Over the last 20 years, our average inflation rate, not healthcare inflation rate, but our average inflation rate in the United States has been around 2% per year. So about 20% over the last 10 years. Over the last 10 years, the average worker's income has gone up by about 26%. So has outpaced inflation by just a bit. The average amount that we're paying for healthcare premiums has gone up 54%. So it's just more than doubled the average worker's income increase. But perhaps the most sobering fact is the average deductible and out-of-pocket spend for the average American has gone up by over 160% in the last 10 years. So when you think about that, healthcare consumers now have to make more and more of an effort to understand value and understand what is going to lead them to get the very best care for the very lowest cost. And it's very interesting when you accept the fact for a moment that cost of care is actually indirectly related, interestingly enough, to the quality of care. So as quality decreases, we actually end up spending more for healthcare. And this is a great example. This comes from 2015, the average Medicare cost per person for the various states around the country. And as it turns out, the states that spend the least are directly related to the states that have the highest quality. And again, this makes sense. As an orthopedic surgeon, I can tell you if I do a hip replacement or a knee replacement for a patient and they don't get readmitted and they don't have an infection and they don't need a reoperation, their costs are clearly going to be lower. Very different than the patient that has a complication and requires further care, who ends up having a much higher spend for their healthcare dollar. As we start thinking about vertically integrated platforms and their capabilities to help drive alignment and drive change, we start thinking more and more about, how do we actually take risk? How do we judge the spend? So if you look today in the United States, we have all kinds of different models where a provider may actually intersect with a payer from going from the standard fee for service all the way up to full global risk. So you have organizations like the Kaisers of the world, for example, which take full global risk and also happen to be the primary provider of healthcare for the patients for which they are taking risk. On the other end of the spectrum, you have organizations that provide only the risk-taking entity, essentially the payer per se, and organizations that provide only the healthcare delivery side. Without a doubt, we are seeing more blurring of those lines. As you see organizations like Optum, for example, an arm of United Healthcare, getting more and more into the healthcare delivery side. Guidewell and Florida Blue getting more and more into the healthcare delivery side. And also organizations that have healthcare delivery that are looking to take more and more of the risk. Various managed care organizations across the country that are now taking more and more of this. So that blurring, I actually see as a great opportunity for us to learn from one another from the traditional roles that we each played, either as a healthcare provider or a healthcare delivery arm versus a quote-unquote payer. So again, we can go from fee-for-service all the way to full global risk, and there's several different steps in the middle, whether you're taking pro-fee cap, bundled payments, shared savings, pay for performance, and the like. And all of these, to be successful in them, require very specific ingredients to give you the ability to be successful. So let's talk for a moment about different types of value-based entities and what has allowed some of them to be successful while others have tended not to be successful. So let's first start with accountable care organizations, ACOs. So if you look at the history of ACOs, these population-based ACOs have, generally speaking, have in fact led to modest per beneficiary savings, but probably most importantly, they've also led to improvements along several different quality dimensions. As you look at some of the characteristics that make ACOs successful versus unsuccessful, one of the clear characteristics that has led to more successful ACOs is if they are led by a physician. We see that they have greater savings, they reduce more hospitalizations, and in fact, they have their participants staying in the programs longer. So if we look at data from 2020, CMS reported on 513 different ACOs in the United States. 67% of them, so 2 out of 3, actually had shared savings. And the total amount of performance payments that went out to those groups was almost $2.3 billion. So again, I mean, that's pretty promising. But not all ACOs succeed. In fact, in the example that I just gave you, 1 out of every 3 did not generate shared savings. So what are some of the characteristics in those ACOs that have led to them not succeeding? I would tell you that these fall into 2 main categories. The first is that the ACO may not have enough lives in it to adequately take risk. So think about this, very simply from a statistical perspective. If you choose to do a clinical study or a statistical study, the more patients in the cohort that you're studying, the smaller your error bars and the higher the likelihood that you'll actually find a difference if it really exists. So as we enroll more and more patients into an ACO, we're able to reduce the error bars for the amount of risk that we're taking, thereby more likely to price our offering more accurately. When you have fewer patients, you end up with much greater variability. So you might win big, but you also might lose big. The other reasons that ACOs have historically failed is because of the introduction of downside risk. And for many ACOs, they've actually been successful in generating upside, but over time, some of that success has waned away, or their prices have reset, and as downside risk was introduced, they've not necessarily been successful. So if we look at some of the Medicare shared savings plans specific to ACOs between 2013 and 2017, about 1 out of every 3 chose to exit the program. Now, why did they choose to exit the program? Number one, the shared savings bonus payments were simply not enough to offset the costs of putting the program in place and managing the program. Another characteristic was perhaps they were in a market where they had a higher benchmark per capita. The third being in markets that had higher Medicare cost growth. So as the targets were reset and got harder and harder to hit, it became more and more difficult for them to actually end up with a shared saving. If they offered more of the 14 possible care coordination services, because in many cases, you may be very, very good at 2 or 3 or 4 things, but maybe not great at all 14. And that was certainly a challenge for some organizations. I already mentioned the fact that bearing downside risk clearly led to more groups exiting. And then finally, ACOs that had sicker patients as measured by higher hierarchical condition categories, the HCC scores. So if they had sicker patients and they didn't quite follow them up appropriately in terms of documentation, it became more and more difficult to actually end up with a shared savings in those groups. So just to give you some examples, and these are big ACOs that are supported by very strong organizations, many of them, as I mentioned, did not succeed in saving money. So Beacon Health, Dartmouth-Hitchcock ACO, Heritage California, all of these owed millions of dollars in losses, at various points received no shared savings payments because they couldn't reach the quality benchmarks. Now, again, I would tell you that all 3 of these organizations are incredibly successful organizations, but having a successful ACO is not necessarily an easy thing to do. Next, let's just change directions here for a few minutes and talk about clinically integrated networks. It's interesting, I specifically put the definition of a clinically integrated network as defined by the Federal Trade Commission very intentionally on the slide. And the reason I put it on the slide is because we have found it very difficult to actually appropriately define a clinically integrated network. And most organizations actually have to go out to an outside law firm that specializes in healthcare compliance to ensure that we're, quote, meeting the definitions as defined by the FTC for true clinical integration. And this can change frequently. So it's very important that if you are, in fact, participating in a clinically integrated network and you are delivering shared savings or potentially even negotiating as a single entity, that, in fact, you do meet the criteria of a CIN. So I'm just going to break these down into a few different things. The first is establishing mechanisms to monitor and control utilization of healthcare services. And it's very important that even if your CIN is being used as a tool to negotiate with payers, you still have to use that CIN to control costs and ensure quality of care. So a CIN is not designed and should not be utilized to simply have more marketing power in a market to try to get higher rates. Second, important that you selectively choose the clinicians in the network who are likely to further these efficiency objectives. So it can't just be everybody that wants to participate can participate. You need to be selective in making sure that the clinicians that are participating have a real desire to move the value curve, increase quality and decrease cost. And the third is the recognition that to create a CIN, there is a requirement for investment of capital, both monetary and human, in creating the necessary infrastructure and the capability to realize the claimed efficiency. So let's talk a little bit about these. Again, as I mentioned before, to create a CIN, You really have to give it careful consideration. You have to be prepared for an investment of time and money. You need to create a quality infrastructure. The CIN needs shared governance amongst the participants, and it needs a clear vision in terms of what it is supposed to be doing. And as I mentioned before, if the idea and the vision for the CIN is simply to create a bargaining tool or a contracting tool to try to get higher rates, that is not aligned with true clinical integration. It's important to recognize that. So some of these challenges are to ensure that the goals of the participants are in fact aligned. And you also need significant trust between the organizations. Most clinically integrated networks are fairly broad in scope and broad in terms of their participants. And it's sometimes difficult to get that trust. In many cases, organizations that have been fierce competitors sometimes for decades, or clinicians that have been competitors for decades, are now coming together for a clinically integrated network. Does require, to some degree, a leap of faith in terms of that trust. The groups have to accept a set of common quality measures and benchmarks. You can't each have your own. It has to be clearly accepted, and it has to truly be in place to drive value. You have to have access to shared data, and you have to have local adoption of the quality improvement activities. So if an organization or a participant chooses not to adopt those activities, they are very likely not going to end up with a distribution from the clinically integrated network. So let's talk about a couple clear successes when it came to clinical integration. So Flagler Hospital in St. Augustine, Florida, has had a very successful CIN. They partnered with over 80 local physicians. They formed the First Coast Health Alliance, and they saw a 65% decrease in excess length of stay, a $3 million decrease in associated costs. Fairview Health Services, Health East and North Memorial Hospital in Minnesota came together and partnered to form the Preferred Health. They saw a significant increase in the number of covered lives that were participating, which, as I mentioned before, is important in terms of being able to save money, because as you have more lives, your risk ends up dropping significantly, because with appropriate data, you ought to be able to have a better sense for exactly how much risk you have. So they went from 7,000 to 40,000 members. They had a superior quality index factor for 5 high-cost conditions: cardiology, endocrinology, GI, orthopedics, and mental health and substance abuse. What that ended up leading to was a 10% differential in premiums paid by employers and employees for the participation in that clinically integrated network, and an 11% decrease in the risk-adjusted total cost of care. Clearly, big wins for both of these organizations. But not all CINs succeed. Why do some of them not succeed? Well, number one, there are barriers of implementation, and these barriers can be very real, whether it's lack of access to high-quality data, lack of interoperability, lack of clinicians coming together and trusting one another, in the finance committees or the quality committees. And then the second big category is time and resource commitment. It's not easy to stand up a CIN. It takes very real time, and it takes very real resources. So here's a good example of a couple CINs that have failed. So the Together Health Network in Michigan was a clinically integrated network, physician-led, but it was never able to achieve optimal performance or the adequate return on the investment that they had made to put this together. Another one, Affirmant Health, which was the largest clinically integrated network in Michigan, chose to disband because the members became more competitive and didn't work together as required by the agreement. So again, thinking through the fact that you need volume, you need trust, and you need to work together really are the key ingredients to being successful in this type of model. I think we're all familiar with the BPCI programs, and these programs have really shown very significant decreases in cost across the United States in just about every area that they've touched. In fact, if you look between October 2018 and December of 2019, CMS reported that for the BPCI advanced models, that they showed a reduction in episode payments by 2.2%, surgical episode payments dropped by 4.5%, readmissions for a 90-day period dropped by 4.1%. They saw a reduction of post-acute care use and reduced number of days in SNFs. So clearly, I think at the federal level, BPCI in many cases would be defined as a success. But in some cases, these types of episodic bundles have not been successful. MD Anderson and Moffitt Cancer Centers, two high-quality, well-recognized, top-of-the-line cancer programs, participated in BPCI, but didn't succeed because they didn't enroll enough numbers of patients because either the entry criteria were too strict in an attempt to narrowly define the risk strata, or because the providers tended to overestimate the potential number of enrollees. The Prometheus pilot, again, Prometheus, very successful program in many cases, but here was a very real challenge. And part of that challenge was because of the complexity of the patient classification and the definitions around the services which were included and excluded. So that made it very difficult. And prior to the original federal BPCI program, United Healthcare's oncology group practice put together their own bundled care initiative in 2009 that had about 800 patients in it, and that failed just because of the cost of chemotherapeutic drugs. They couldn't get their costs under control, and that program ended up failing. So it's interesting as we look at these programs, we frequently look at them from the perspective of the healthcare provider, the healthcare system, the physician, the advanced practice providers. But let's look at it for just a moment from the perspective of the payers. So this was actually a very interesting survey that was done by Change Healthcare, where they looked at 120 different payers. And what they found on the payer side was that through the use of value-based care models, this was very general, they felt that 80% of them reported that it improved the quality of care. 73% saw an improvement in patient engagement. 64% reported better relationships with healthcare providers. 66% were so optimistic about the programs that they actually hired more staff to offer more value-based programs. And on average, they saw about a 5.6% medical cost savings. What were the biggest challenges that they saw? Well, about half of them reported extreme difficulty in getting doctors on board, and over 50% were unhappy with their own analytics and automation and the ability to report on the successes and failures of these programs. So much of the failure in many value-based care scenarios has really been tagged with this idea of the race time. We hear that term all the time. We reset our goals. We race to the bottom. Why does it happen? Well, we clearly understand that there's downward pressure on costs in the United States. And candidly, I would argue that that's not a bad thing. We are truly, today, in terms of our costs, not able to continue with the healthcare inflationary rates that we've seen. So there ought to be some downward pressure on costs. In addition to that downward pressure on costs, there ought to be more upward pressure on quality. So the race to the bottom we see is frequently related to the idea that cost cutting is the predominant lever. What I would instead promote to you is that as we improve quality, costs will automatically come down. So if you strongly tie your value-based program to cost in a fee-for-service heavy model, the likelihood of seeing success there that is, in fact, reproducible and long-lasting becomes minimal. So I would argue that the drive here ought to be to build something that is consistent, transferable, successful, and based on quality, and you will find that the cost follows in a decreasing fashion as quality goes up. That really is, I think, the key to being successful. So let me give you an example. We talked quite a bit about bundles, and bundles today I think are fairly popular, both because of the CJR model as well as the BPCI model. So when we look at most bundles today, they require some type of a trigger, right? A decision for surgery, for example, which would be the trigger event that then enrolls you in a bundle. Once the trigger event occurs, there's then the potential for savings, which on average lasts about 90 days after a procedure. So that may include the pre-op workup, the surgery itself, the hospital stay, the post-acute care, and the post-op therapy. Well, as it turns out, that surgical episode is just a small part of the entire continuum of care. In fact, if you look at the cost of treating knee pain or knee arthritis, the surgical episode is only 25% of the overall annual spend for knee pain. In fact, for spine, for lower back pain, the surgical episode is only 9% of the annual spend. So if you really work your tail off and you take 10% out of the cost of a total knee replacement episode, you're only taking 2.5% out of the entire continuum of care. If you take 10% out of the cost of a surgical spine episode, you're only taking 0.9% out of the spend. So the saving potential, I would surmise to you, should really be based on the much larger entire continuum of care. So when you do that and you start looking beyond the traditional focus and you start looking at opportunities to start saving money through improved quality over the entire continuum of care, it becomes a much larger pool to take cost out of. So looking at indications, for example, for advanced imaging, standardizing clinical care pathways, not only for surgery, but also for diagnoses, agreed upon management for non-surgical condition. And for those that need surgery, accelerating their pathway to getting their surgery done and minimizing the various treatments that may not necessarily put off their surgery or reduce the likelihood that they're going to need surgery. In addition, after a procedure, we clearly know that there are evidence-based treatments that have durable outcomes and reduce unnecessary returns to the operating room. So all of these are opportunities to take out costs that in many cases, when you're dealing only with procedural episodes, are ignored. So these really give us much more of an opportunity to take out costs. I would surmise to you that perhaps one of the most important aspects of having a successful value-based care program is access to high-quality, accurate data. And if I look back over the course of the last decades where value-based care has seen mixed results, it's candidly because I believe that there hasn't been enough accurate, transparent data that has flown to providers in a way that has allowed them to change the way they treat patients to lead to the very best outcomes. I'm also of the very honest opinion that when providers are given the right tools, that they will invariably do the right thing. So to be able to use data in a meaningful way and to take that data and make it meaningful, actionable knowledge, you need to have the ability to ingest and organize claims data from multiple payers and develop actionable plans based on that. You need to identify opportunities for savings all the way down to the level of the individual provider. What I might do may be very different than what many of my colleagues might do. So it's important to recognize what each individual provider is doing to be able to coach that provider and develop action plans and physician incentive programs that are tailored to meet the needs of each population at the individual provider level, because each one of us may practice a little bit differently. We need to actively monitor progress, manage to the targets, and direct the operations of the network. You can't just stand up a network or just stand up an ACO and hope that things will follow their own path. You have to actively manage it if you truly expect to be successful. Finally, you need to be able to provide feedback to the clinicians and empower them to champion efforts that they believe really will lead to improved quality. You'll notice that I'm purposefully saying improved quality because, again, as I mentioned before, as we improve quality, cost will follow in a decreasing fashion. And then finally, be able to predictably improve quality and reduce cost. Some of the work that we do, for example, is having standardized order sets, standardized clinical pathways and protocols, not only for procedures, but for diagnoses like new onset groin pain. I would let you know that from my perspective, as an orthopedic surgeon, if a patient comes to me with new onset groin pain, they get a very specific workup. If they go and see a general surgeon, they may get a very different workup. If they go and see a gynecologist, they may get yet a third workup. it's important that we recognize that there is clear, data-driven, peer-reviewed data that supports how a diagnosis of new onset groin pain ought to be worked up. And as we get better and better at standardizing some of these types of treatment plans and workups, we will find that we will be able to improve the quality of care for the patient and at the same time reduce the unnecessary costs that that patient is undergoing today in their workup. So as you build a program and you want it to be an effective value-based care or population health model, I actually believe that these are the absolute necessary steps. A, you need accurate data sources. That's an absolute must. Two, you need real-time data analytics. And those analytics have to lead to information and knowledge that can be acted upon. You need the clinicians to be engaged. If they're not engaged, there isn't enough data in the world to change their actions. You need rapid feedback. You need to give folks immediate feedback on how the program is working. Are they being successful? And if not, can we help you to be successful? And you need aligned incentives. So it needs to be important to the patient, to the payer, to the provider, to the healthcare system, that these are the right things to do for these reasons. When all of these things are in place, then we are able to engage with one another further upstream, improve the quality of care, and thereby reduce the costs. Now, once you have these types of things in place, how do you actually reward folks? So the reward should be based on value, not just taking out costs. So in our case, what we usually recommend is that you set several quality targets, and as you meet specific targets, you're bonused based on how many of those targets they met. So some of these targets may be adherence to wellness protocols, some of the protocols that I just shared with you a few minutes ago. Reduction in unjustified care. So are you getting an MRI on a first visit for a patient with 1 week of shoulder pain? That would not be supported by the literature. So therefore, if you did that more often than would be expected, you would miss out on that target. Appropriate site of service shift for indicated patients. Very important here. It's not about just moving patients to lower cost of care sites. It's moving the right patients to lower cost of care sites and ensuring that the appropriate patients that need an inpatient facility or a higher acuity facility are in fact taken care of at that facility. And then finally, reduction of readmissions, where I would say, I think we would all agree would be a benefit. There are good examples of site of service optimization savings. In fact, in the orthopedic world, we really learned a lot about this from the obstetrics literature. And if you all remember back in the 1990s, the rate of VBACs, vaginal birth after cesarean, had really plummeted. So if a patient had gone in, a mom had gone in and had their first child through cesarean section, it was almost automatic that the second child would also be born through cesarean sections. Well, the payers really kind of got together with a group of influential and intelligent obstetricians that really knew the data and said, look, there's no reason to do that. In most cases, after a cesarean section, a patient can be very carefully and appropriately treated by a vaginal birth. So what they did was they actually bumped up the reimbursement for the physician for a VBAC, a vaginal birth after cesarean, and through doing that, reduced the overall cost of care for that episode. So here in this example, you can see for total joint replacement, if you can actually reduce the payment at the hospital level or even move it to an outpatient ASC and incentivize the clinician to do that in a compliant, orderly, ethical fashion for the right patient by moving them to that ASC. And then you can see that the total cost of care decreases. And I would suggest that you'd likely agree with me that if in fact you are eligible for surgery in an outpatient setting or in an ASC, the likely patient experience improvements are really quite dramatic. Most patients would obviously prefer to have their care there. And then again, keep in mind, given what I shared with you in terms of the cost of care, that is now more and more often the responsibility of the patient, because of that shift, the patient has the opportunity to have less out-of-pocket cost as well as potentially higher patient experience as that shift occurs. The last area that I really want to focus on here is really talking about the trend in healthcare spend and recognizing, is in an effort to try to avoid this race to the bottom, that we recognize that in fact there is a trend for increased cost of care in healthcare. As I mentioned before, last year, the healthcare inflation rate in the United States was 10%. The 10 to 20% increase in healthcare spending in musculoskeletal care has actually been sustained now for several years pre-pandemic, and that has really continued. So when you look today at how the trend works in healthcare, if you look at year one, if you set a goal of a 10% decrease in cost, that's terrific. Now, if you meet half of that, you'll find that by year two, you still have 5% available to you to continue to work towards. But if you layer in the fact that there's a 15% year-over-year trend, you've actually taken 20% of savings out and have continued opportunity to save even more moving forward. So it's important to recognize that trend is actually a very important number when you are negotiating in terms of your savings. Finally, touching on the whole idea around the comprehensive analysis and implementation, it is absolutely incredibly important that organizations today have the sufficient infrastructure for appropriate data collection, analytics, and reproducibility of clinical performance and results. Again, we know high volume sites and high volume clinicians, generally speaking, have better results than low volume facilities and low volume clinicians. Why? Because when you're doing high volumes, you become a more highly reliable organization. So the way to introduce higher levels of reliability, even at lower volumes, is to use standardized order sets, standardized clinical care pathways, and the such. You need to establish those capabilities in-house or engage with organizations that can work with you to provide such capabilities. And then finally, by doing that, you create a sustainable organization, not just a sustainable payer model. And I think that's really the key, is you really want to build something that is sustainable towards value and isn't just kind of a flash in the pan that might save you money for a year or two, but instead is something that is based on high quality that will last for a very, very long time. So as I mentioned before, putting into place robust and active clinical care pathways, whether it's through your care management, your clinical protocols, layering on some of these different care management call plans, for example, to ensure that patients are in fact engaged and are part of the conversation, is extraordinarily important. And then also recognizing that the appropriate use of good subject matter experts to identify opportunities is key. Saving money isn't about avoidance of care. It is about getting patients the right care at the right time. So to give you an example, if I see a patient for the very first visit who has absolutely advanced knee arthritis, even if they haven't had significant conservative therapy up to this point, if they have a 20-degree flexion contracture, a severe varus deformity, I know that all the physical therapy in the world, all the injections in the world are not going to end up allowing that patient to not end up with a knee replacement. For that type of patient, they should just go ahead and get their surgery. On the other hand, for patients that are significantly overweight, that have a correctable deformity, patients that have moderate arthritis, right? For those folks, you do want to have a trial of physical therapy. You do want to try injections or anti-inflammatories as appropriate. So again, the key here is the right patient getting the right care at the right time in the right place. It's not about withholding care or delaying care. And when you do this well, you can really save money. This is an example of a clinically integrated network that we were partnered in the Phoenix, Arizona market, all for musculoskeletal care, taking risk on 26,000 ICD-10 codes that were focused only on musculoskeletal health. So this was about 20% of the spend for the insurance company represented these 26,000 ICD-10 codes. And you can see that prior to the launch of the program, we were running at anywhere between a 10 to 15% annual trend in the cost of musculoskeletal care. After launching the program, we bent that cost curve, drove down the inflationary spend, and over the course of about 18 months were able to actually lead to a deflationary spend in the musculoskeletal spend in that market, all the way to about $32 million of savings a year on 100,000 lives. So in summary, I would suggest to you that this should really be a race to value, not a race to the bottom. To be successful, we recognize that the downward pressure on costs will continue, and we should be prepared for that if we're going to stay ahead of the curve. We don't have the luxury of focusing only on the clinical care aspect, but the key for true success is to improve value and improve outcomes and quality. We need to use clinical expertise to identify and design opportunities. And what we really ought to be doing is engaging in our capabilities now to provide the analytics, operational abilities to participate in these models. Thank you very much for your attention.
So, Dr. Barsoum, there are several follow-up questions that I hope you don't mind. I'm just going to ask as the order in which they came in. There were many questions around solving the challenge of the accuracy and availability of claims data to be successful in value-based care models. How have you approached that challenge?
Yeah, I think that's a great question, Daniel. The first thing I would say is I think it's important, whether you're on the payer side or whether you're on the healthcare delivery side. And as I mentioned before, in many cases, those lines have blurred, with payers becoming healthcare delivery organizations as well, and providers taking on more risk. I think we all have to recognize that we need to have some level of trust in one another. Historically, there's always been, I would argue to some degree, in many cases, an unhealthy push-pull between these organizations. I think more and more recently, we've seen more trust occurring between the payers and the providers, and I think that's an absolute key. Getting access to accurate data is the absolute key. And in many cases, the payers have the best data in terms of claims data, so being able to access that data, but also recognizing that as a provider of care and as a subspecialized provider of care, you may have an ability to really comb through that data in a meaningful way that can lead to a back and forth sharing of best practices between, both the deliverer of care and the payer for that care. So, building that trust between both organizations, both groups, I think is absolutely key. But I can share with you that without access to high quality, accurate data, it is very hard to have a successful value-based care program.
Thank you. The next question is there a critical mass needed for a population health program to be successful?
Yeah, I think that's a good question. I think it all depends on the type of program that you're talking about. So if it's a shared savings program, not really. I mean, you're going to have some cost associated with that. So you obviously want to make sure that you cover your costs in terms of education, in terms of, whatever resources you need to ensure its success. But in a shared savings program, it's kind of an upside only deal. As soon as you start taking downside risk, there is absolutely a critical mass. And that critical mass is likely dependent on several things. Number one, how many different things are you taking risk on? So in other words, if you're a large vertically integrated healthcare system that's going to take risk on a global spend, you need a lot of lives in that. 5,000 lives is likely not going to be enough. 10,000 lives is likely not going to be enough. You really probably need to be in the several tens of thousand lives to really make sure that you're hedged appropriately from a downside level. But probably more importantly than the number of lives is the infrastructure and the quality of your medical economics team to ensure that you price that model out correctly. So I think that's kind of a long answer to a fairly straightforward question. But the reality of it is it really comes down to the type of model, the breadth of the model, and the capabilities of the organization to price out the risk appropriately.
Thank you. Another question, what's the average length of time from investment to returns for organizations who move from fee-for-service to value-based care?
Yeah, so first of all, I would say it's very rare that I'm not sure that I've really ever seen anybody that has literally just flipped a switch and gone from fee-for-service to a true 100% value-based care type of arrangement. That usually takes years. But let's say you wanted to go from fee-for-service for total hip and total knee replacement to a value-based care model like a procedural bundle. There's really no reason that you shouldn't be able to see significant savings in the first year. In fact, there's so much data out there today that shows kind of the low-hanging fruit around site of service shift, appropriate advanced imaging reduction, reduction of use of post-acute care facilities, even utilizing home-based therapy programs that are available on the internet. That's pretty low-hanging fruit. And I think we've got a lot of data out there, and much of that is kind of publicly reported and fairly straightforward. So that ought to work pretty quickly. As you start getting into bigger programs around global health, now you have to really educate larger groups around appropriate documentation and scoring, and the importance of being accurate with that documentation. There are many programs where you're taking global risk, and you need to see patients more often to ensure that their chronic medical conditions are managed more appropriately. So if you're going to do that, you have to shift from very large panels of patients in primary care, maybe from 2,000 patients down to 500 patients. That may all sound great, but one of the challenges that we have in the United States is we don't have enough primary care providers. So, those models are wonderful for the X hundred of patients that got into it. But the problem is it's also led to us having a longer and longer wait for new patients to get in with primary care providers. Here in the United States, the average wait to see a new patient with a primary care provider is well over 20 days. Those are challenges that we have to deal with at the same time. So again, long answer to, I think, a very straightforward question, but it really does come down to what kind of value-based care model are you looking to get into? If it's a focused model with good data, you ought to be able to see returns clearly within the year that you've launched the program. If it's a larger model that where you have to do a lot of education and build major infrastructure for, it may take several years. But in the end, it's likely worth the investment if your focus is on quality and not on cost.
Got it. What are some of the incentives needed to get physicians to engage in value-based care if they're a little bit reticent? And are those incentives only financial?
Yeah, I don't think that they're only financial. Look, everybody that went to medical school or became an advanced practice provider, is a wildly motivated person, right? I mean, you don't end up getting into medical school or going to PA school or nurse practitioner school because you weren't motivated and because you didn't study hard and because you didn't want to help patients, right? All of those things I would propose to you are kind of foundational. So to motivate the folks like that, including myself, I'm an orthopedic surgeon, certainly money plays a role, but so does reputation. You don't want to be the provider that people feel, isn't necessarily thoughtful or objective in terms of the care that they provide. Steerage of patients can certainly be a strong motivator. I remember, obviously, being a provider that was on the receiving end of many consults and many referrals from my primary care colleagues, rheumatology colleagues, always gave me a source to be proud of. I came, for many years practicing at the Cleveland Clinic where we were all salaried. So there was really no financial incentive to doing more surgery. Instead, it was a pride incentive, right? That you were busy and that you worked hard and people liked you and people wanted to trust you with their patients. That's a very real incentive and a very meaningful incentive. But I think in the grand scheme of things, probably the three things that are the strongest incentivizers for clinicians are: number one, money; number two, steerage; number three, reputation. And those are not in any specific order, but those are probably the three largest incentives for most providers today.
Got it. Next question is, which specific conditions or subspecialties do you feel have the most opportunity to improve quality and reduce costs?
Yeah, that's a great question. So if you look today at obviously the largest spend that we have is musculoskeletal care. So, I don't mean for that to come across as self-serving, but musculoskeletal care is clearly a huge opportunity. It's about 1/6 of the national spend today, actually growing. It's probably today about 1/5 of the national spend in healthcare. And that spend is, we've gotten our hands around some of it, but most providers, that are in a value-based care program are in a very limited value-based care program. Like I said before, maybe CJR or BPCI, but they're not taking population health in major ways. They may be getting some steerage from an ACO and maybe a small bonus payment from that. And many are not using standardized clinical care paths. So I would say that's a big opportunity. The second big spend in healthcare today, as you know, is cardiac care and then oncology care. But when you look at those two areas, those have really become pretty well self-governed. If you look at the STS, the Society for Thoracic Surgery, they've done an incredible job for decades in terms of judging cardiac surgery program by how many stars they get. And you have to follow specific protocols, and you have to have very clear, strong outcomes. And that program actually revolutionized cardiac quality in the United States. The same in oncology care, right? Oncology care and cardiac care, those are, what I would refer to in many ways as team sports. You're not, as an oncologist, you're not working alone with the patient, right? It's usually an oncologic surgeon. It may be a radiation oncologist as well as the medical oncologist. There's a whole team around that patient. And in many cases, they communicate and they talk about the care that the patient's getting. So it's kind of hard to be, kind of a cowboy in that type of a model. Same with cardiac care. Usually they have a cardiologist. You've got the cardiac surgeon. You may have an interventional cardiologist, a vascular medicine doc, or a vascular surgeon, all involved. So when you have teams of patients that are using clearly defined clinical care pathways, it becomes easier and easier to improve the quality of care and thereby see a reduction in the overall cost of care. So, the low-hanging fruit, in my view, is clearly musculoskeletal care. I think the other area where we see a fair amount of variability is in primary care. And much of that, has to do with following the pathways that are out there today, and recognizing that many of those pathways change every year, right? What's the right age to get your first colonoscopy if you don't have any risk factors? It used to be 50. Now it's gone down to 45. That just changed a few years ago. When's the right time to get your first mammogram if you have risk factors or if you don't have risk factors? All of these things are constantly changing. And I think to be on the cutting edge and the leading edge of value-based care, you have to be willing to stay up to date on all of the peer-reviewed data that really shares the best practices in those areas.
Thank you. Another question: how do you best balance the need to standardize clinical pathways and practices while also allowing for the attention to the individual needs of the patient and their circumstances?
Yeah, that's a great question. So let me tell you firsthand how we do it at Healthcare Outcomes Performance Company. So what we do is in our clinically integrated networks, as I mentioned before, we may set 5 different variables with each one having a target to get your full bonus payment from a clinically integrated network. It's never our expectation that you will hit 100% to get the full bonus. So in other words, for use for discharge to home versus post-acute care, it may very well be that the expectation is that 95% of your patients are going to go home as opposed to post-acute care. Now, it may very well be that your data shows that all of your patients could have gone home, but you chose to send 1 or 2 to a SNF or to an acute rehab facility. Well, it may very well be that those patients didn't have consistent help at home, or maybe they did have help at home, but their spouse or their loved one had just recently had a stroke or had a chronic medical condition. So, the predictive models that we might use might not quite answer for that. So what I would suggest is you never want to set your quality goals at 100% for somebody to get a quality payment. You have to have some flexibility to allow the clinician to use their best judgment in what is best for the patient, because you never want the incentive to outweigh the safety profile of what's best for the patient. So you always need a little bit of flexibility to allow the clinician to make what they believe is the right choice in conjunction with their patients.
Good. I think we have time for one more question. The aging baby boomer population is going to increase healthcare costs. How do we decide how much savings we can realistically achieve with their needs?
Yeah, I think a lot of this comes down to a couple of things. When you talk to folks who are experts in wellness and longevity, it's interesting. Their goal in many cases isn't necessarily for all of us to live to 115 or years of age. That's not really it. The goal is to live a healthy, chronic disease-free life for as long as possible, and then when it's time to die, that you get sick and you pass, right? That you don't have a long, drawn-out period of time where you're in the hospital or seeing doctors or being in an intensive care unit, but instead that you live a long, healthy life, and then when it's time to die, you die, quickly. And I know that may sound a little bit crass, but that really is the goal. I think that's what we would all want for ourselves and for our loved ones, is to not see them suffer. So much of the cost of healthcare occurs in that last 6 months of life or the last 1 or 2 years of life, where we are dealing with chronic disease and chronic illness. So, just having baby boomers getting older isn't necessarily going to need to more healthcare costs if, in fact, we can get our arms around the ideas of incorporating more wellness and appropriate preventative care into our lives. If you look at the United States today, we spend an average of $10,000 per American for healthcare every day. If you look at the Medicare cost, it is also about $10,000 per American today. Why is that? Well, because younger patients are also, having more car accidents. They're involved in more injuries that may require long, protracted hospital stays. So, it's not so much that if you're a 30 or 40-year-old, your cost of care is so much less than if you're 70 years old. It's just a different spend in your care in many cases. But it is, without a doubt, that last 6 to 12 months of life where we have major opportunities to reduce the spend of healthcare if we can be more preventative and more thoughtful in the way we live our lives.
Thank you. I think we just have time for one more. One of the primary limitations to establishing an effective network is the availability of data. How can HOPCo and others in the market access the volume of data needed to establish these performance targets?
Yeah, so that's not necessarily an easy thing to do. So just to be clear, I think organizations like an Intermountain Health, organizations like Kaiser, like Geisinger, they have that infrastructure built in. At HOPCo, for example, we've spent 15 years building that infrastructure and have spent over $100 million in building that infrastructure. We have, past insurance executives. The chief actuary for Blue Cross and Blue Shield of Massachusetts works for HOPCo. One of the founders and chief financial officer for Pacific Care works at HOPCo. One of the executives from Aetna for the Mountain States works at HOPCo. One of our board members was the CEO of Optum Care. Right, having that quality of individual on your medical economics team with an infrastructure that you spent over $100 million on to be able to ingest claims data and look for opportunities is the key to being successful. And again, like I said, it's not that we're the only organization that does that, but to my knowledge, we're one of the only organizations that aren't essentially a large healthcare system that has an insurance arm built into it, like an Intermountain or like a Geisinger or like a Kaiser. So, it takes time. And it takes expertise, but it's, in my view, it's an absolute must to be successful in value-based care.
Thank you, Dr. Barsoum.
Thank you. I just want to thank everybody for. I'd just like to thank everyone for. Go ahead, please.
That's all the time we have for today's webinar. I wanted to thank Dr. Barsoum for an excellent presentation and Healthcare Outcomes Performance Company for sponsoring today's webinar. To learn more about the content presented today, please check out the resources section on your webinar console to fill out the post-webinar survey. Thank you for joining us today, and we hope you have a wonderful afternoon.